Olga, would you get us started, and then I'll pitch it to Tom next. Yeah,
Okay.
thank you.
Terrific, thank you. It's really good to be with you today, and because I can ramble on, I'm putting a stopwatch on for myself. I find that I really wanted to start with a quick story, which is a compilation of true events, but compiled from a number of different stories. Because although I'm an academic and really believe in the power of data and facts, I also think that sometimes we get desensitized a little by the data, and we sometimes forget what we're talking about. And so I really thought if we could just quickly, I could share a story with you about what children are really facing. And I'm going to focus a little bit more of my talk on behavioral health as a function of what we're talking about in terms of children's well-being. But
Before you jump into your story,
Yeah.
my apologies because I was about to cough.
Yeah.
Would you briefly introduce yourself?
Oh,
since
absolutely.
I didn't get to.
Yeah,
Thank
absolutely.
you.
I'm sorry. I am Olga Acosta Price. I am Associate Director at the Milken Institute School of Public Health here at GW. I'm also Director of the Center for Health and Healthcare in Schools, a National Resource and Technical Assistance Center. Sure, absolutely. So I'm going to tell you a little bit about Rasul. He's a 12-year-old who recently began 7th grade in a town outside of Philadelphia. A few years ago, his family fled from Iraq as refugees, and Rasul would recount memories of how his mother wouldn't let him play outside when he was very small because it was too dangerous, and he often couldn't attend school because of the violence on the streets. When he was 7, one of Rasul's older siblings was kidnapped, and militants killed several of his relatives. His mother explained how, due to the violence, she couldn't even go out to the store without fearing for her life. When he was 9, Rasul's family resettled to a refugee camp in Jordan, where, while they were safe from the fighting, they really faced harsh living conditions. His family lived in a very tight, crowded tent that was donated to the camp, and food was difficult to come by, and water was sometimes scarce. The crowded conditions in the camp promoted the spread of disease, and Rasul and his family fell ill on a number of occasions. His family did successfully apply through the UN High Commissioner for Refugee to resettle in the U.S. After an extensive screening process that left Rasul's family living in the camp's miserable conditions for almost 3 years, they were finally resettled to the U.S. And while the family was really excited to rebuild their lives, new challenges would face them when they got here. His adjustment to his new school and neighborhood was far from smooth. He spoke very little English. He was not familiar with any of the social norms that we sort of take for granted, and he had no friends for support. Other students regularly bullied him for being different, for not being able to speak English, for not understanding how to function in school. Students referred to him as terrorist and asked if he had bombs in his backpack. An even further disheartened part of the situation is that some teachers turned a blind eye when Rasul was being bullied, and on one occasion even participated in the creation of these hostile environments by making racist comments like it was probably a family member that caused the 9/11 attacks, and people like you should be banned from the country. In addition to being excluded and feeling alienated, Rasul struggled in the classroom. He was often really discouraged when he couldn't keep pace with his classmates. He found himself in school suspension several times for being disruptive and fighting with other children and refusing to follow instructions. School administrators and staff became frustrated because they felt just really unable to get through to him. Sometimes Rasul was placed in isolation cubicles during his in-school suspension, really with the intent to help him focus on schoolwork. But little did the staff know that forcing him to sit in those confined spaces was actually triggering traumatic memories for him. They knew little about his background and the stresses that he had to endure, even though he was very young. After seeing little improvement in his situation, an administrator decided to call in a school family liaison from an externally funded school-based health program conducted by a community partner in the neighborhood to meet with and help Rasul and his family. The liaison was of Middle Eastern descent, spoke Arabic, which helped Rasul immediately feel at ease. She spoke with him about his experiences in school, in the classroom environment, about his new life in the U.S., and through her conversations with him, the liaison also learned how many adverse childhood experiences he had experienced and decided to refer him to the nurse and to the school health center, where a nurse practitioner could do a physical exam and also provide co-located behavioral health services to him to do a mental health assessment and treatment. They contacted his parents to explain the services, obtained their consent, and he began receiving services. In addition to attending to his health needs, in which he had some chronic health conditions that were really impacting his ability to be function in schools. The school-based health center encouraged him to participate in a cognitive behavioral treatment group to address his trauma symptoms, told his parents about the Parent Welcome Center that could help link them to supports outside of the school. The school itself had made a commitment to become a trauma-informed school, or to adopt principles of trauma-informed, and they were focused on wellness and mindfulness and ways to really get some of those practices into the school day. After 4 months of regular participation in care through the school-based health center, Rasul was engaged in school. He had no more disruptive or aggressive outbursts. He had made a couple of friends, and he could name several adults who he knew he could go to if he needed help within the building. He smiled more often, and he was even overheard telling a peer that he'd like to be a teacher when he grows up. So I start there because, I watched the previous panel as a way to kind of get a sense of how these conversations go, and I was struck by something that Randy Weingarten had said at the last, the last convening that happened after the election, is she said, we must stop the hate and address the fear that pervades many schools. The fear really does interfere with learning development and undermines health. We do really know that, but I think we have to underscore how it's really impacting our young people. Although Rasul may seem like an extreme example, we do need to recognize that our public schools are really increasingly diverse, and this is a national demographic shift. It is not only occurring in our resettlement areas around the U.S. According to the Migration Policy Institute, in 2015, about 25% of children aged 6 to 17 were from immigrant or refugee families. That doesn't mean they themselves were first-generation immigrant, but they may be second-generation immigrant. Sadly, Rasul isn't alone in facing some of this marginalization. About a third of 2,000 educators recently surveyed by the Southern Poverty Law Center in a report called The Trump Effect, the Impact of the Presidential Campaign on Our Nation's Schools. They reported that there appears to be an increase, they concluded there appears to be an increase in anti-Muslim and anti-immigrant sentiment that's being expressed more openly in schools. The majority of the teachers surveyed for that report indicated that students, mainly immigrant and children of immigrants and Muslims, expressed themselves concerns or fears about what would happen to them or their families. And although they don't tout to be a representative sample of teachers from across the country, it does point to areas of concern for incidents like these that exacerbate the stress that already impact our vulnerable and marginalized students like Rasul, who are dealing with accumulated pre-migration, migration, and post-migration trauma. The issue is not one only impacting, though, immigrant or refugee kids. In the U.S., across the board, a staggering number of children and adolescents suffer from preventable emotional and behavioral health problems. Our estimates consistently show that 1 in 5 children exhibit signs and symptoms of emotional and behavioral problems severe enough to warrant clinical intervention. We also know that estimates say at least 10% of adolescents experience 4 or more adverse conditions or adverse childhood events per parent reports, which may be an indication of underreporting for some of those, and that the impact of these experiences really follow adolescents all the way into adulthood and through adulthood. Our retrospective studies suggest that half of the adults diagnosed with mental illness can trace their first symptoms back to age 14 and 75% to age 24. So we're talking about the prevalence of these, the incidence of these happening much earlier than maybe we once suspected. Coupled this information with what we know about the degree of poverty that our children are living in, data from the National Center for Education Statistics, for instance, indicated that more than half of students in public schools now meet federal requirements for free and reduced lunch, which you probably already know, but it's important to keep those statistics in front of us. The stressors associated with living in disadvantaged environments are linked to poor emotional behavioral functioning as well as physical health functioning, and contribute to disparities in educational attainment and health. So the greater exposure to these experiences, we do know, again, from the data, are more highly associated with disengagement from school, lower academic performance, and negative consequences in life, like poor adult health, poor emotional well-being, higher rates of chronic disease, and even mortality. So although behavioral health problems are pervasive, studies reveal that 1 in 4 students exhibiting these do not really get care in the preceding year. So we know that it is a big problem, and yet a lot of our young people are not getting care. Fewer students, even with substance use problems, are likely to obtain treatment. Estimated at less than 10%. So the majority of those who seek and receive that care, and those of you working in schools would know this probably, that you do so in schools. You're more likely to receive quality care and reliable care in schools. So schools really are a promising and effective setting for prevention, early identification, and treatment of health problems, particularly in this case, as I'm talking about behavioral health problems, really due to a school's potential for providing access to consistent, high-quality care associated with a number of positive outcomes. So we do know, though, that we can assert pretty strongly that unhealthy kids have a very difficult time learning. And that learning, it's well understood that schools alone are not capable of addressing the complex needs that are presented by students and their families, and that effective solutions really require these kinds of innovative models in collaboration with healthcare networks, hospital systems, community health providers, and educators in schools. So what helped Rasul and other students like him, whether as I said, these school-connected models, you'll probably hear about a number of them, school mental health programs, community school models, community in-school models. We know about SEL in school climate initiatives, about even things that have are in primary care settings, the integration of mental health in primary care. But I want to spend my last few minutes talking about school-based health centers as one of the models. They provide accessible and comprehensive health care to students in grades K to 12, and through partnerships between schools and what we call sponsoring agencies. These are healthcare institutions, federally qualified health centers, FQHCs, community health, in which you bring interdisciplinary health providers and a team that's co-located, integrated into the school system, very often in partnership with the school nurse. The driving force behind the development of school-based health centers, which originated in the 80s as a model of care, was to ensure that all students in public schools had primary care and preventative services, because the data was showing us that wasn't the case, particularly for adolescents. Today, school-based health centers offer an expanded scope of coordinated care for those in public and public charter schools, and providing primary care. In addition to that, more than 2/3 have co-located behavioral health services. 1 in 5 provide oral health exams by dentists or dental hygienists also in schools. And in total, they reach more than 2 million children and adolescents in over 2,300 centers nationwide. So they've been really known to address what we might, in the healthcare world, refer to in the triple aim, reducing cost per capita, improving public health, and providing high-quality care. We do know studies show that, and with regard to cost, that school-based health centers help save Medicaid more than $30 per student per year. Other studies have shown they reduce inappropriate ER use and overall hospitalization costs, that they've improved access and eliminated many barriers to physical and behavioral health care services. And this is especially true for our most high-risk students, particularly those that we know underutilize health services, like ethnic minority youth and adolescent boys in particular, who are known not to do that. So I want to just, I guess, in addition to improving access to care, obviously we do know that these co-located models really help reduce chronic absenteeism, disruptive behaviors in school, and allow us to chip away at the social and environmental determinants that prevent children and their families from maintaining good health and linkages made to community supports and social services across the spectrum. So the evidence of their ability to promote health equity has really been substantiated enough that the Community Preventative Services Task Force recommends implementing school-based health centers nationwide, particularly in low-income communities. So this is really one that has been touted by nationally and by the federal government as a strong approach to addressing these disparities. So if I was going to say, what are my sort of quick takeaways, because I think we'll hear more about some of these models, and I'm happy when we have questions and answers to talk more about this one in particular. The takeaways: health and learning, we really now fully understand, are inextricably linked. We can't hope for good outcomes in one without attending to the other. So the approaches to drive improvements in educational attainment must include health strategies and aims to address disparities in health for children that have to include a meaningful way that schools are a part of this solution. School-based health centers are one effective model for integrated healthcare prevention and wellness, but only 2,300 exist nationwide. And there's a number of challenges. I had shared a paper that I had done that illuminates and sort of lays out what some of those structural challenges are, but in particular the use of public financing and as a way to support the flourishing of those centers is one that I think we'll be able to link to as part of our discussion. I also want to just end with saying, schools we know are a microcosm, a reflection of the broader social ills that we face. So when we tackle some of these underlying conditions that drive health and educational disparities, when we call out institutional racism and sexism, and when we promote policies and practices that really ensure an equal playing field for all of our students and for all of our children, then we're going to experience true well-being in and out of schools. So thank you. I'll end there.